So anyhow, I think we'll just continue until they fix the technical problems, is really looking at what are the new faces of diabetes. And nowadays, we don't any longer think of diabetes as just one type of type 2 diabetes, neither when it comes to type 1 diabetes. Very similar to what Carl has told you when I'm treating anemia or when I treat a breast cancer, is not, all of people with breast cancer would get all the treatments the same as everyone. And this is where we're changing our thinking and how we're advancing our care. Okay. So if we take this, and if I ask you, this comes from the diabetes clinic, which clinic do you think it is with this distribution? You think it's the type 2, type 1? Which clinic do you think it is? So this is, when we used to think of diabetes,
wow, that's what. Which one do you want?
So when we used to think of type 1 diabetes, we always thought of type 1 diabetes as a diabetes that is in the young people, they are lean people, and that's where we have to change now across the spectrum. So we're seeing more of the type 1 diabetes is diagnosed later in adult life, and we know that many of the type 1 diabetes also becoming overweight and obese. And if I just show you the incidence of type 1 diabetes, you see half of the people living with type 1 diabetes are diagnosed at an adult age. So this is a shift of our thinking. And now when it comes to what we have done since the discovery of insulin, we know that we have now celebrated 100 years of insulin therapy. And what are we offering our type 1 diabetes? We're trying to offer better insulin therapy, better technology, a lot of educational and personal factors. But we haven't really improved care for type 1 diabetes much, and still more than 50% of people would have an A1C of more than 50%. And when we look at the DCCT trial and the original trial, we know that with intensive control, we can improve the retinopathy, neuropathy, and nephropathy, but that was an expense of the hypoglycemia and weight gain and a lot of glycemic variability. So it really opens ourselves into we have to really offer these people something. So we want to reduce hypoglycemia, we definitely want to reduce variability, we want to reduce insulin needs, and we have to look at the obesity within the type 1 diabetes. So thinking again of reclassifying diabetes and looking at what can we offer as an adjunctive therapies for people with type 1 diabetes. So now looking at obesity in type 1 diabetes, it's a new face of the type 1 diabetes that we often ignore. Whenever we're still looking at care of our type 1 diabetes, we think of them, they're lean, and we're just focusing on the glucocentric, on their A1C, on time in range, on glycemic variability, not really addressing any of the obesity. And it's really, difficult to say that until today, there is not a single guideline that address obesity in type 1 diabetes. With all the advancements of the obesity world, this is still missing. And when we think of the obesity, it's always about not the weight loss, it's the health gain. So you have seen how the guidelines have evolved over the years, and we're looking through them as complication-centric, but none of them address the type 1 diabetes with obesity. Many people think might not be a problem, and it's not a huge thing, and that's why people not addressing it. So this is the work that we have done with Dr. Abdelnabi Al-Attar and with our international groups from Mexico and Belgium, and this is the abstract that has been accepted in both the ECO and the ESD, showing you what is the population for the type 1 diabetes in the general obesity comparing to the general population. And you would see from this, which is intriguing, that about 23% of type 1 diabetes will have BMI more than 30. So it's a huge problem. And you have almost 40% they will have a BMI of 25 to 29. So you would see it's a highly prevalent in the type 1 diabetes, almost mirroring our general population. So the gray is our general population, people without diabetes, comparing them to people with type 1 diabetes. And you see it's a huge problem that we often disregard and don't think of it and shy away from it. And still today, when we're looking at our consultations, most of us as a healthcare professionals, we're looking at their downloads when it comes to type 1 diabetes, focusing on their insulin pumps, on their technology. and really, not addressing the obesity in them. And this is where is the mismatch between our healthcare professionals and the patients. So this really has addressed us to move, and we have published this with the group of a review in the Lancet in Diabetes Endocrinology looking at obesity in people with type 1 diabetes. And what are the real challenges? We know the obesity prevalence is increasing in type 1 diabetes. Until today, not a single guideline, and most literature is always focusing on the type 2 diabetes. We do not understand the mechanisms yet. We know insulin treatment is a must for the type 1 diabetes, and that is associated with weight gain. And those people also suffer from, people with type 1 diabetes suffer from, hypoglycemia, so they will do defensive snacking to avoid the hypoglycemia. Exercise in type 1 diabetes is an area that is much, avoided because people with type 1 diabetes are worried of, hypoglycemia, and that's why we have now the educational tools like XTOD and, Daphne to improve the people with type 1 diabetes. And we know that obesity leads to insulin resistance and dyslipidemia and cardiometabolic complications in the type 1 diabetes. Again, you see our type 1 diabetes, we're often thinking of them as a glucocentric, focusing on our downloads, focusing on time and range, and avoiding the obesity as so. And there is really lack of the clinical guidelines, and that's what makes life a bit harder when it comes. And we know insulin promotes weight gain, and this we have seen it in DCCT trial that, have resulted at least of 5 kilogram weight gain just with intensive insulin therapy. So what are the possible mechanisms of weight gain? We really don't understand it. So is it improved glycemia? And we know that the increased conservation of calories, these might be, some of this is due to the, the peripheral insulin that we use bypasses the liver. Industry is looking for liver-specific insulins, but we haven't been very, yet ambitious about it or got there, and what are the risks associated with it. So when we're looking at, type 1 diabetes and thinking of pre-obesity and obesity, we know that there are factors that we can't change, but we know that there are the other changes, that the hormonal changes, the risk of hypoglycemia and insulin will all promote to obesity. There are medications that when I was in the US, we use often in the type 1 diabetes, that's the pramlintide, and that delays the gastric emptying, suppresses glucose secretion, and reduces the fat. And there is the 1-year RCT, it has significant weight loss of about 0.4 compared to 0.8 kilogram in the people with type 1 diabetes. When we're looking for the adjunctive therapy, so how do we do if we put these patients on, GLP-1 analogs on people on type 1 diabetes? And now what we need to be specific here, and that's what I see a lot of mispractice, is many people use the obesity, the diabetes dose for these medications when they're treating the obesity and type 1 diabetes. And that is where, you see a lot of the mismatch and the results. So I see a lot of medications that are not obesity medications, that are GLP-1 medication used in the type 1 diabetes. So we have many trials that has been conducted, and there are of different durations, so just to put them for you. So most of them have gone up to 52 weeks with the varying doses, and you can see both on the changes of the A1C and the weight loss in our population of type 1 diabetes. What about when we use the SGLT2? We know the SGLT2 are contraindicated in type 1 diabetes because of the increased risk of the ketoacidosis. So, but these are, the trials that has, it was approved in the European EMA, but it was withdrawn, for the dapagliflozin in type 1 diabetes. So, but these are the results of the changes in the A1C and the weight loss associated. So it's not only associated with improved, weight loss, but it's also improving the glucose variability, which we know is a huge problem. But again, you have the risk of the DKA, so you have to really warn the people about it. So with this, we have recently published this year, our retrospective data from our clinic looking at the GLP-1 use and the SGLT2, in obesity in the type 1 diabetes. So these are our data from the Daspan Diabetes Institute in, people within our clinics. All these patients are Daphne patients, so they are highly educated patients who, can run a lot of the intensive management of their insulin. And when we look at, what we have looked at is look at people who are controlled versus people who were put on GLP-1 versus people who were put on a combination therapy versus people who were put on SGLT2. And here we try to demonstrate for you both the weight loss and, the HbA1c. And you see the marked improvements for the glycemic variability and the HbA1c reduction for the people in type 1 diabetes. But again, you have to use it with caution with, a highly dedicated group of type 1 diabetes. And if you want to see the percentage changes of the HbA1c in the different treatment group, again, you will see, when you have the combination therapy, you're getting an extra benefit, not only on the A1C, but also on the weight changes. And this is the 12-month study that we looked at retrospective data. This has really, fueled us to move to audit trial. This is, a randomized control trial. Again, our nephrologist from the Amiri Hospital is, part of this trial, where we're looking at people with type 1 diabetes and really define the metabolic pathways and the mechanistic, of the use of the GLP-1 and SGLT2, not only people with type 1 diabetes, but it's a type 1 diabetes with CKD. So it makes even recruitment harder and the life is more difficult, but this is what we're looking for the study. So this is a randomized control trial. We have completed the recruitment, but we're still awaiting for the last patient to complete their 6 months before we can share the results with you. What about bariatric surgery in type 1 diabetes? Again, in Kuwait, we have published this from the Amiri group, as the people with type 1 diabetes who has undergone bariatric surgery. And what you would see that the effect on both the A1C and the post-surgery in BMI. Of course, here's the mechanistic and the mechanisms is different. You would, where you have, there is no studies yet, there is a conflicting studies in the literature regarding the improvement of the A1C in people with bariatric surgery. So it's a tool that is often offered for the type 2 diabetes where it can cause remission, but when you offer it to type 1 diabetes, the literature is really mixed, and that's mainly due to the increased risk of hypoglycemia. We look after these patients, and after the surgery, they become a nightmare really to control their hypoglycemia. And no matter what technology we're using, because of the differences in the gastric emptying and the delay of the absorptions and the pharmacokinetic of the insulins, so it becomes a definite struggle with it. You definitely see a reduction of their insulin dosages. You definitely have the decreased risk of cardiovascular disease, but we're here with the complication of surgery, nutrition, and increased risk of DKA. So there has been reported that there are increased risk of DKA, but most likely what you see is the increased risk of hypoglycemia. So looking back at type 1 diabetes, what can we really offer them? It's been 100 years since the insulin therapy. And we're still just offering them insulin therapy, just improving our insulin therapy through technology and through pumps. And really shying away from a huge prevalence problem that is not only in Kuwait, but I showed you the effect in both in Belgium and Mexico and many people around the world that no one is addressing. And more so, most of the pharmaceutical company today not running any clinical trials in our people with type 1 diabetes. So it's astonishing to me, people who are producing your GLP-1 and the new medications are all originally type 1, pharmaceutical companies, but when it comes to running clinical trials, they're mainly focusing on the type 2 diabetes and obesity. So we definitely need more research into this area, and that's where we want the collaboration among everyone in Kuwait. We know that type 1 is a more challenging people because you have the higher risk of hypoglycemia, you have the higher weight regain, due to hypoglycemia and stacking. We do have the bariatric surgery in them, but we know there's an increased risk of hypoglycemia and DKA. And the pharmaceuticals still is restricted by authorizations, and it has a high cost as well. And, we have the contraindications of some of the medications with increased risk of DKA and, whether people would like to have an injection therapy. But I have really shared with you our data, retrospective data that was published in Obesity, showing the improved benefit for the people of type 1 diabetes if it is used and handled with extra care in a population that is well trained. So, our type 1 diabetes are already stigmatized, and the social media is a lot of stigmatization, with our type 1 diabetes. Add to it now is the obesity, in addition to the stigma that is associated with obesity. So it becomes even a harder problem. And we really have to start thinking away from weight-centric, glucocentric when it comes to type 1 diabetes, and looking at the patient from the holistic point of view, what additional therapy we can give them for weight, not for weight loss, but for health gain. This is some of the qualitative work that is, currently done, and you will hear more about Sophia. So where Kuwait now is, thanks to Carl and the group, is part of the Sophia group, and Dr. Dalal Al-Saeed is now conducting the qualitative studies, on people with type 1 diabetes and obesity. So this is, has been just published recently, just saying how people with type 1 diabetes view things and how obesity really affects people, with the diabetes. So just to say, how people, we don't even think about it, even when it's shopping, branding, and other things, they really struggle with it. And, where they often, might not be able to get into their clothes that we think it's trivial, but they think it's a huge thing. So when we're prescribing today, we should prescribe for health gain, not for cosmetic reasons. And that's, again, a big thing that we have to do. And we really need to start shifting our thinking. Because if we do the same thing back and back and back again, we're just going to get the same old results. So we have to really shift the thinking is type 1 diabetes is no longer a disease of the children, is no longer, they're lean and, they don't have obesity. It's really overweight and obesity exists in our people with type 1 diabetes, and we really need to think and target the obesity in them. And that's where we have to think of it. We have to use every single tool that we have today, but, it's not pyramid anymore. If you believe in, in the obesity management as pyramid, you should leave it to Egypt history, so it doesn't belong to us anymore. It's it's a more, not a linear process. It's a combination of whatever you can offer to the people in tool and therapy. So I hope by the end I really convinced you that obesity is a complex and chronic disease, and it is really coexisting with type 1 diabetes. And patients living with, type 1 diabetes should not be excluded from obesity treatment. And there is a real need for guidelines for people with type 1 diabetes and obesity. And we have to start changing our thinking. And with this, I would like to thank the whole team, and everyone works, in Dasman. And Dasman has a very close collaboration with, the Amiri Hospital, where they have added a lot, and it's many of the thanks to Dr. Abdelnabi Al-Attar, who has pioneered of the Daphne program, in the Dasman Diabetes Institute. And with this, I would like to also announce that Jumana Al-Kindiri and her team has just won the Diabetes UK Education Award last week, and that's all of the great work that Jumana from the Amiri Hospital and the Dasman is doing for the Daphne, and they've won just last week the Diabetes UK Education Award on the national level of the UK. Thank you all for the great invitation, and thank you always for the great collaborations that we have with the Amiri Hospital. They're very grateful too. Thank you.